going to discuss on anemia, its definition, classification and approach to diagnosis. So first we are coming to the definition. What is the definition of anemia? That is a reduction in the concentration of circulating hemoglobin or oxygen carrying capacity of the blood below the level that is expected for a healthy person of the same age and sex in the same environment. That is what I mean, that is specified for sex and age, not a range that is specific for all. It depends on the level, depends on the sex and the age. In case of a adult male, the normal level is 13.17 gram per deciliter. In case of adult female, it is 12 to 15 gram per deciliter who is non-pregnant. In case of pregnancy, there is some reasons, mainly iron deficiency anemia or hemodilution causing some fall in hemoglobin level. In case of pregnant women, it is 11 to 14 gram per deciliter, that is normal level. In case of children, that is 6 to 12 years of age, what is the normal level of hemoglobin? It is 11.5 to 15.5 gram per deciliter. Children 6 months to 6 years, that is more younger, normal level of hemoglobin is 11 to 14 gram per deciliter. In case of infants, that is 2 months to 6 months age, normal level of hemoglobin is 9.5 to 14 gram per deciliter. And in case of newborn, it is small higher, that is 13.6 to 19.6 gram per deciliter. So, these are the normal level of hemoglobin. Now, we are grading the anemia. We are grading anemia in 3 categories. 3টে ক্যাটাগরিতে আমরা ভাগ করতে পারি। One is mild. Mild কাকে বলবো? What is mild? That is hemoglobin from the lower limit of normal. The normal limit I have already shown in previous slide. That is the normal limit, lower limit of the normal to the 10 gram per deciliter. That is mild form of anemia. Next, coming to the moderate. Moderate is 10 to 7 gram per deciliter. That is moderate anemia. And when you call it severe, when it is below 7 gram per deciliter. It's up to this is clear to everyone. Is there any confusion? If there is any confusion, please ask me after the class. Okay, I will explain. So, up to this, we have learned what is anemia, that is definition of anemia, normal level of anemia, normal level of hemoglobin concentration, and after that, we have learned the grading of anemia. Now, we are coming to the classification. How do we classify anemia? Numerous classification of anemia has been proposed. অনেকগুলো ধরন আছে যেভাবে ক্লাসিফাই করা যায়। The most acceptable one is based on the etiology. Etiology means how the anemia is caused, cause of the anemia, etiological. Broadly, anemias can be classified into 3 categories. That is, anemias produced by blood loss. Second, due to failure of erythrocyte production, there is defect in RBC production, and due to increased destruction, due to so many causes, more destruction of RBCs than it is produced. So, there is imbalance of production and existing number of RBCs causing anemia. Each one of these categories may have a number of disorders. Anemias may also be categorized according to the red cell morphology into microcytic, macrocytic or normocytic anemia. So, how do we define the size, microcytic? I am talking about the size, microcytic, macrocytic and normocytic anemia. It is the in peripheral blood smear the size of a nucleus of a small lymphocyte, that is a lymphocyte, and RBC is like that, much paler. The size of a সবাই কি দেখতে পাচ্ছে? দেখা যাচ্ছে না? Comparison is made between the size of a nucleus of a small lymphocyte with the RBC. When the RBC size is equal to the nucleus of a small lymphocyte, it is normocytic. When size is equal to the nucleus of a small lymphocyte. When we are seeing a peripheral blood smear, we found the blood cells along with the WBCs. We compared the size of a RBC with the nucleus of a small lymphocyte. When the size is equal, it is called normocytic, which I have mentioned, normocytic. So, when the size of RBC and nucleus of a small lymphocyte is equal, it is called normocytic. Size is equal, it is called normocytic. When the size of nucleus is smaller, it is macrocytic. RBC size is bigger than the size of the nucleus of a small lymphocyte. Size is bigger, it is called macrocytic. Macro means big, and size of RBC when smaller, it is called microcytic. So, it is clear we are comparing the size with the nucleus of a small lymphocyte on a peripheral blood smear. How this macro, micro and normo, these terms are came, I am explaining that. Normocytic when the size of RBC is equal with the size of a nucleus of a small lymphocyte, that is normocytic. When the size is bigger, RBC size is bigger than the nucleus, that is macrocytic, and when the size is smaller, it is microcytic. In fact, it's more accurate and easier for pathologists to follow this classification, that is normocytic. What we see in under microscope in oil immersion field, we see these sizes of RBC. Thus, anemias are first classified according to the morphology, and then based on further investigation and clinical details, they are classified etiologically. So, first we are coming classification of anemia according to morphology. Microcytic hypochromic, that is the nucleus size, RBC size is smaller than the nuclear size of lymphocyte. Microcytic কোথায় কোথায় হয়? In iron deficiency anemia, thalassemia, sideroblastic anemia and anemia of chronic diseases. That is examples of microcytic hypochromic anemia. Now, coming to the second point, macrocytic. Macrocytic means big, boro. The size of RBC is bigger than the nucleus of a small lymphocyte. Examples are megaloblastic anemia and aplastic anemia. Okay. Now coming to the normocytic, when the size of the RBC and the nucleus of the small lymphocyte is equal, that is called normocytic. Normocytic anemia examples are hemolytic anemias, anemia of chronic disorder and anemias due to acute blood loss. এটা মুছে দিই, ক্লিয়ার, বোঝা গেছে, সবাই দেখতে পেয়েছে? Anyway, now coming to the classification of anemia according to etiology. I was talking about the anemia classification according to morphology, size. Now coming to the classification of anemia according to etiology. That means the cause. What is the cause of anemia? Behind the anemia, what is the cause? Number one, anemia due to blood loss. Causes are GIT, that is GI tract bleeding, DUB, dysfunctional uterine bleeding. Number three, menorrhagia. And number four, accident and trauma. Now coming to the second point, that is anemia due to failure of erythrocyte production. RBC production e gondogol hocche. There are sub-classification. What are the causes of failure of erythrocyte production? A, proliferation and differentiation defect in stem cell and progenitor cell. What are stem cell and progenitor cell? They are the mother cell. They produces the RBCs. There are few causes, that is aplastic anemia, paroxysmal nocturnal hemoglobinuria, leukemias and myelodysplastic syndrome. Number B, nutritional deficiency. Due to deficiency of some nutrients, red cell production may be hampered. That is nutritional deficiency anemia. That is megaloblastic anemia. Causes are vitamin B12 deficiency and iron deficiency anemia. Obviously, there is iron and folic acid deficiency. Number three, we are coming to number C, that is dyserythropoiesis. What does it mean? Means dyserythropoiesis. Erythropoiesis is going on, but there is a defect, that is not a perfect production. There is some defect in erythropoiesis. Examples are sideroblastic anemia and refractory anemia. Next, the anemia of chronic disorders. Some chronic disorders, some infections and inflammation may cause anemia. That is, we call anemia of chronic disorder. Up to this, clear to everyone? Okay. We are coming to third point, that is anemia is due to increased destruction. RBC production is good, but there is increased destruction. RBC is produced, but destruction is more than the production. That's why there is deficiency and causing anemia. There are also some sub-classification, that is intrinsic membrane defect. The cause of destruction lies in the membrane. Intrinsic membrane defect causing hereditary spherocytosis. It is an inborn defect. There is defect in sprectin causing the membrane of RBC is not proper. It became like a sphere. RBC looked like a chapter, a disc-like structure. But due to membrane defect, it becomes spherical and prone to destruction, destroyed easily. So, hereditary spherocytosis, it is an example of intrinsic membrane defect anemia. B is enzyme defect. There is some enzymes which causes destruction of RBC easily, that is J6PD, that is glucose 6-phosphate dehydrogenase enzyme and pyruvate kinase enzyme deficiency, both the enzymes causing more easy destruction of RBCs causing anemia. Number C, hemoglobinopathies. Hemoglobinopathies, what are these? Hemoglobinopathies are hemoglobins are produced, but there is some defect. That is number 1, thalassemia example. Thalassemia is very common. We all know the name thalassemia. And sickle cell disease. In sickle cell disease, RBC become shape became like a sickle, like a kaster moto, a sickle like shape. RBC cell became like this. Sickle cell disease. And number D, some acquired defect. Example is paroxysmal nocturnal hemoglobinuria again. So, up to this we have discussed the definition, normal levels, grading and classification of anemia. Up to this clear to everyone? Okay. Now, we are going to the next part, that is approach to the diagnosis of anemia. How do we diagnose anemia in laboratory or when a patient come to us? What are the sign symptoms? What are the causes of anemia, etc., etc. Okay. So, anemia can result from variety of causes. Investigation in a case of anemia should be directed towards answering the following questions. Is anemia present, and if so, what is its severity? Anemia ki shotti ache thakle the severity kotota. And number 2, what is the cause of anemia? The karonta ki. In most cases, presence of anemia can be established with the help of clinical findings and few simple investigation. First, we assess the patient clinically. When you go to the clinics, the first thing you should learn, that is clinical examination part, anemia, cyanosis, jaundice, clubbing, edema. First thing is anemia. Anemia kothay kothay dekha hoy? Conjunctiva, tongue and nail bed. First thing, establishing the presence and severity of anemia. First, we are going to establish that this patient having anemia. How to establish this? Establishing the presence and severity of anemia. Tests for these purposes are very simple, that is estimation of hemoglobin concentration and packed cell volume, PCV. Very simple investigation. Hemoglobin estimation. First, we are coming to the hemoglobin estimation. Various methods available, like A, colorimetric method. What is colorimetric method? It is color comparison made between known standard and the the test sample, either visually or by photoelectric colorimeter. Color comparison করে দেখা হয় যে একটা known standard আমরা জানি, তার এগেইনস্টে একটা চার্ট দেওয়া আছে এবং আমরা যে স্যাম্পল যে টেস্টটাকে যে স্যাম্পলটাকে টেস্ট করতে চাইছি তার সাথে এটা কম্পেয়ার করে এটা করা হয়। এটাকে বলা হয় কলোরিমেট্রিক মেথড, যেহেতু কালার কম্পারিজন করে জিনিসটা করা হচ্ছে। এরপর আসি ভিজুয়াল মেথড। ভিজুয়াল মেথড কি? Shalley's acid hematylin method. It is inaccurate and just a theoretical, just for a theoretical knowledge, not practically it is done. We are coming to WHO hemoglobin color scale. It is very simple, inexpensive and reliable for those labs where photoelectric colorimeter is not available. একদম বেসিক লেভেল ল্যাবে বা একদম বেড সাইডে, পেশেন্ট যখন বেড সাইডে আছে ইমিডিয়েটলি আমাকে জানতে হবে এর হিমোগ্লোবিন কত আছে। একটা মোটামুটি লেভেল জানা যায়, একটা WHO এর একটা কালার বা চার্ট দেওয়া আছে যে এই কালার হলে এত হিমোগ্লোবিন হতে পারে, এই কালার হলে এত হিমোগ্লোবিন হতে পারে, সেটা চোখে দেখে মিলিয়ে একটা মোটামুটি একটা বেডসাইড প্রসিডিউর, এটা স্ট্যান্ডার্ড ল্যাব প্রসিডিউর হিসেবে ধরা হয় না, কিন্তু এটা খুব সিম্পল, ইনএক্সপেন্সিভ এবং খুব তাড়াতাড়ি করা যায় বলে বেডসাইড প্রসেসে কখনো কখনো আমরা যখন ছাত্র ছিলাম আমরা দেখেছি এগুলো করতে, কিন্তু এটা নট রিলায়েবল ফর ল্যাব টেস্ট, এটাকে আমরা রেফারেল হিসাবে বলতে পারবো না। ঠিক আছে, এরপর আসছে মেথডস ইউজিং ফটো ইলেকট্রিক ক্যালোরিমিটার, যেখানে ফটো ইলেকট্রিক ক্যালোরিমিটার দিয়েই কালার কম্পারিজনটা করা হয়। আমরা চোখে দেখে করছি না, সেটা কিন্তু মেশিনে করা হচ্ছে এই কালার কম্পারিজনটা, যেটা যাতে মোর অ্যাকিউরেট হয়। তো প্রথমেই আমরা কি চলে আসছি, সায়ানোমেথিমোগ্লোবিন মেথড, এটা মোস্ট অ্যাকিউরেট অ্যান্ড রেকমেন্ডেড, এটাই মোস্ট অফ দ্য ল্যাবে করা হয়, এখনো এইটাই চলে। নাম্বার 2, এগুলো জাস্ট থিওরিটিক্যালি জেনে রাখার জন্য, অক্সিহিমোগ্লোবিন মেথড, ইট ইজ রিলায়েবল দো নট stable standard available for this, just for theoretical knowledge. And alkaline hematine method, it is also accurate, but আমরা বেশি করি যেটা, সেটা হলো সায়ানোমেথিমোগ্লোবিন মেথড, এটাই চলে। নাম্বার বি, গ্যাসোমেট্রিক মেথড, these all are obsolete now, that is not practiced, but for theoretical knowledge we have to know what are the methods of hemoglobin estimation, other methods. That is gasometric method. Oxygen carrying capacity of blood is measured in von Schleicke's apparatus. It is not suitable for routine use, it is for theoretical knowledge. Number C, chemical method. Iron content of blood is measured and value of hemoglobin is calculated indirectly. It is tedious and time consuming, that's why it is not also in use. D, specific gravity method. Specific gravity method, which bolbe? It is simple, rapid and inexpensive, with a rough estimation of hemoglobin is obtained from specific gravity of blood used for mass screening like selection of blood donors. আমরা যখন ব্লাড ডোনার সিলেক্ট করি তখন দেখতে হয় যে ডোনারের যাতে নিজের অ্যানিমিয়া না থাকে, সেটা দেখার জন্য তখন প্রচুর লোক থাকে, সেখানে তো এরকম সবার হিমোগ্লোবিন করা সম্ভব নয়, সেখানে স্পেসিফিক গ্র্যাভিটি মেথড মানে কি, জাস্ট ওটাকে দাঁড় করিয়ে রাখা হয় ব্লাডটাকে, ওটা সেটেল ডাউন করে যায়, সেটা দেখে একটা আন্দাজ করা হয় যে কতটা এর আদৌ অ্যানিমিয়া আছে কি নেই, যদি অ্যানিমিয়া না থাকে তবে তার ব্লাডটা নেওয়া হবে, নয়তো নেওয়া হবে না। ঠিক আছে, তো সেটার জন্য স্পেসিফিক গ্র্যাভিটি মেথড, এটা একটা মাস স্ক্রিনিং এর জন্য কাজে লাগানো হয়, লাইক ব্লাড ডোনেশন ক্যাম্পস। ঠিক আছে, এবার একটু ডিটেলস বলবো, সেটা হচ্ছে সায়ানোমেথিমোগ্লোবিন মেথড, যেটা এখন রিকমেন্ডেড মেথড অ্যান্ড রিকমেন্ডেড বাই ইন্টারন্যাশনাল কমিটি ফর স্ট্যান্ডার্ডাইজেশন ইন হিমাটোলজি, যেটা ল্যাবে আমরা অ্যাকচুয়ালি ল্যাব প্র্যাকটিসে করি। কি করা হয় এখানে, এখানে স্পেসিফাইড অ্যামাউন্ট অফ ব্লাড ইজ মিক্সড উইথ ড্রাফটিন সলিউশন। ড্রাফটিন সলিউশন কাকে বলি, এটা কমার্শিয়ালি অ্যাভেলেবেল ল্যাবে থাকে। এটাতে কি কি থাকে, পটাশিয়াম ফেরিসায়ানাইড অ্যান্ড পটাশিয়াম সায়ানাইড, এই দুটো কম্পাউন্ড একসাথে থাকে ড্রাফটিন সলিউশনে। বাংলা বলছি মাঝে মাঝে, অসুবিধা হচ্ছে না তো বুঝতে? ঠিক আছে। So in drafting solution it is actually mixture of two, potassium ferricyanide and potassium cyanide. Potassium ferricyanide এর কাজ কি, potassium ferricyanide converts hemoglobin to methemoglobin. potassium ferricyanide রিঅ্যাক্ট করলো হিমোগ্লোবিনের সাথে এবং সেটাকে কনভার্ট করে দিল মেথিমোগ্লোবিনে। নেক্সট কামস potassium cyanide. Potassium cyanide reacts with methemoglobin and convert it to the cyanomethemoglobin. ঠিক আছে, after completion of this reaction the absorbance of this solution is measured in a spectrophotometer and 550 nanometer. ঠিক আছে, এই ওয়েভলেন্থে এটা অটোমেটিক্যালি মেশিন এটাকে রিড করছে, চোখে দেখে নয়। এটা আমরা স্পেকট্রোফটোমিটারে এই অ্যাবজর্বেন্ট যেটা হলো সেটাকে রিড করে হিমোগ্লোবিনের ঠিকঠাক এস্টিমেশনটা দিচ্ছে। এটাই মোটামুটি। এটা কি আরেকবার বলবো, বুঝতে অসুবিধা হলো কিছু? দ্য ড্রাফটিং সলিউশন ইট ইজ কমার্শিয়ালি অ্যাভেলেবল, ল্যাবে এটা থাকে। এটাতে কি থাকে? দুটো জিনিস থাকে, পটাশিয়াম ফেরিসাইনাইড অ্যান্ড পটাশিয়াম সায়ানাইড, দুটো সলিউশন মিক্সচার থাকে। এবং পটাশিয়াম ফেরিসাইনাইড কনভার্ট করে হিমোগ্লোবিনকে টু মেথিমোগ্লোবিন। মেথিমোগ্লোবিন এবার কম্বাইন করছে পটাশিয়াম সায়ানাইডের সাথে টু ফর্ম সায়ানোমেথিমোগ্লোবিন। এই যে সায়ানোমেথিমোগ্লোবিন, এই যে রিয়াকশনের ফলে যে অ্যাবজর্বেন্সটা হলো, এইটাকে মেজার করা হচ্ছে স্পেকট্রোফটোমিটারে অ্যাট 540 ন্যানোমিটারে করে, সেখান থেকে হিমোগ্লোবিন এস্টিমেশন করা হচ্ছে। Next, coming to the determination of PCV, that is packed cell volume. PCV is the volume of packed red cells obtained after centrifugation of a sample of anticoagulated venous or capillary blood. Venous or capillary blood যেটা আমরা ড্র করি, তাতে অ্যান্টিকোয়াগুলেশন মেশানো আছে, সেটাকে সেন্ট্রিফিউজ করা হয়। সেন্ট্রিফিউজ করার পরে, সবই মেশিনে করা হয়, ল্যাবে এগুলো হয়, তোমাদেরকে প্র্যাকটিক্যালি দেখিয়ে দেওয়া হবে। আমি ওই জন্য টেস্টের খুব একটা ডিটেলসে যাচ্ছি না, নয়তো শেষ হবে না। করে এটাকে করা হয়, এটাকে দাঁড় করিয়ে রাখা হয়, একটা টিউব আছে, সেটাকে সেটেল ডাউন করতে দেওয়া হয়, এবং ওই যে প্যাক সেল যে পরিমাণ আরবিসি সেটেল ডাউন করলো, এটাকে বলা হয় প্যাক সেল, সেটাকে মেজার করা হয়। ইট ইজ এক্সপ্রেসড অ্যাজ এ পার্সেন্টেজ অফ ভলিউম অফ হোল ব্লাড অর অ্যাজ এ ডেসিমেল ফ্র্যাকশন। এতে কত পার্সেন্টেজ আরবিসি সেটেল ডাউন করলো, এটাকে এইভাবে পার্সেন্টেজ হিসাবে বলা হয়। আচ্ছা, ইউজেস অফ পিসিবি, কেন আমরা এত কাণ্ড করে পিসিবিটা করব, কি কি ইউজ আছে? ডিটেকশন অফ অ্যানিমিয়া অ্যান্ড পলিসাইথেমিয়া। পলিসাইথেমিয়াটা কি? পলিসাইথেমিয়া হচ্ছে অ্যানিমিয়ার উল্টোটা, ঠিক আছে? এখানে আরবিসি কম, পলিসাইথেমিয়াতে আরবিসি সংখ্যা বেশি, যে কোনো কারণেই হোক। পলি মানেই হচ্ছে মেনি, অনেক। তো পলিসাইথেমিয়াতে এবং অ্যানিমিয়াতে ডিটেকশন করার জন্য আমরা পিসিবি ইউজ করি। নাম্বার 2 আসছে ক্যালকুলেশন অফ রেড সেল ইন্ডিসেস। রেড সেল ইন্ডিসেস কি? এগুলো কতগুলো প্যারামিটার আছে। মিন কর্পাসকুলার ভলিউম, এমসিভি, এগুলো কিভাবে ক্যালকুলেট করে, এগুলো সবই যে কোনো ল্যাবে গেলে তোমরা দেখতে পাবে। আমি খুব ডিটেলসে যাচ্ছি না, তার কারণ এটা ডিটেলসে বলতে গেলে অনেক বড় হয়ে যাবে। প্যাক সেল ভলিউম ইন পার্সেন্টেজ অ্যান্ড রেড সেল কাউন্ট ইন মিলিয়ন পার সেন্টিমিটার, এটা হচ্ছে এমসিভির ভ্যালু, এইভাবে বার করা হয়। এর ইউনিট হচ্ছে ফেমটোলিটার, ঠিক আছে, এমসিভি। তারপরে আসে মিন সেল হিমোগ্লোবিন কনসেন্ট্রেশন, এমসিএইচসি। এগুলো সবই হুইচ টাইপ অফ অ্যানিমিয়া, এটা ডিটারমিন করতে এই ইন্ডিসেসগুলো কাজে লাগে। নাম্বার 3 হচ্ছে চেকিং দ্য অ্যাকিউরেসি অফ হিমোগ্লোবিন ভ্যালু। এখানে পিসিভির সাথে একটা হিমোগ্লোবিনের সম্পর্ক আছে। পিসিভি হিমোগ্লোবিন পার্সেন্টেজ ইনটু 3 ইজ ইকুয়াল টু পিসিভি। এটা মোটামুটি একটা রাফলি রুল অফ 3 আছে। এটা তার মধ্যে রাফলি আমরা এইভাবে চেক করি যে আমরা ঠিকঠাক দেখলাম কিনা, কোনো প্রবলেম হলো কিনা। আমরা নিজেরা যারা ল্যাবে কাজ করি তারা আমরা এইভাবে চেক করে নিই যে হিমোগ্লোবিনের যে ভ্যালু এসছে ইনটু 3 করলে যেটা হবে সেটা হচ্ছে পিসিভি, ঠিক আছে? তাহলে চেকিং দ্য অ্যাকিউরেসি অফ হিমোগ্লোবিন ভ্যালু, পিসিবি দেখে আমরা কিন্তু ব্যাক ক্যালকুলেশন করে হিমোগ্লোবিনটা একবার চেক করে নিই যে হিমোগ্লোবিন যেটা বেরোলো মেশিন ঠিক দিয়েছে তো, আমার কোনো ভুল ছিল না তো। এটা ইনটু 3 করলে পিসিবির মানে পিসিবির 1/3 হচ্ছে হিমোগ্লোবিন। এটা মোটামুটি একটা রাফ এস্টিমেশন। তো এই করে আমরা কিন্তু এর অ্যাকিউরেসিটা চেক করে নিই। এর মেথড আছে যেটা আমি একটুখানি বললাম, উইন্ট্রপ মেথড, আর একটা হচ্ছে মাইক্রো হিমাটোক্রিট মেথড। আমি এর ডিটেলসে যাচ্ছি না, তার কারণ এগুলো প্র্যাকটিক্যালে তোমাদেরকে দেখানো হবে। নাও কামিং টু দ্য নেক্সট পার্ট, দ্যাট ইজ ডিটারমিনিং দ্য, তাহলে ওটা এস্টাবলিশ হয়ে গেল যে অ্যানিমিয়া আছে এবং তার সিভিয়ারিটি কতটা। সেটার জন্য আমরা কি কি করলাম? হিমোগ্লোবিন এস্টিমেশন এবং পিসিভি, প্যাক সেল ভলিউম। নাও কামিং টু দ্য নেক্সট পার্ট, দ্যাট ইজ ডিটারমিনিং দ্য কজ অফ অ্যানিমিয়া। When the presence of anemia is established, the next step is to determine the cause of anemia. So, we have to know the important causes of anemia in India. India te ঠিক কি কি কারণে আমরা অ্যানিমিয়া বেশি পাই। Number 1, that is nutritional deficiency. What are the nutrients? That is iron, folate and vitamin B12. Deficiency of these nutrients may cause nutritional deficiency anemia. Iron cause iron deficiency, folate and B12 causes megaloblastic anemia. Number 2, few infections like TB, malaria, kala-jar, HIV infection and hookworm infestation all are causing anemia. Number 3, inherited, that is inborn, thalassemias, very common. Sickle cell disease, I just talked about. G6PD deficiency, all are inherited form of anemias. And number 4, blood loss. In most cases, it is obstetrics problems, blood loss in obstetric cases. That is the important causes of anemia in our country. Now we are coming to the clinical evaluation. Patient esche, what are the sign and symptom of anemia? Sign and symptom of anemia, first, that is obviously pallor. Pallor কোথায় কোথায় চেক করতে হয় বলেছি? লোয়ার লিড অফ কনজাংটিভা, নেল বেড, টাং, এই জায়গাগুলোতে দেখতে হয় পেশেন্ট একটা প্যালার নিয়ে প্রেজেন্ট করছে, ফ্যাকাশে হয়ে গেছে পেশেন্ট। ইজি ফ্যাটিগুলিটি, পেশেন্ট খুব তাড়াতাড়ি ক্লান্ত হয়ে যাচ্ছে। ট্যাকিকার্ডিয়া, এফর্ট ডিসমিয়া, কিছু করতে গেলে হাঁপ ধরে যায়, যেন পেশেন্ট এসে বলবে হাঁপ ধরে যাচ্ছে কাজ করতে গেলে। অ্যান্ড in very severe cases, there may be congestive cardiac failure. When hemoglobin percentage is below 4-5, patient may present with congestive cardiac failure. Now coming to the second part, patient তো এলো, আমরা পেশেন্টকে ক্লিনিক্যালি দেখলাম। সেকেন্ড পার্ট যেটা করতে হয়, হিস্ট্রি টেকিং, পেশেন্টের থেকে হিস্ট্রি নিতে হয়। তো অ্যানিমিয়ার জন্য রেলেভেন্ট কি কি হিস্ট্রি আমরা নেব, যে কোন কোন হিস্ট্রি আমাকে জানতে হবে পেশেন্টের অ্যানিমিয়ার কজ জানার জন্য, যে পেশেন্ট একটা অ্যানিমিয়া নিয়ে প্রেজেন্ট করছে তার কি কি হিস্ট্রি জানবো। নাম্বার 1 হচ্ছে হিস্ট্রি অফ ক্রনিক ব্লাড লস আছে কিনা। ইজ দেয়ার এনি হিস্ট্রি অফ ক্রনিক ব্লাড লস, অনেকদিন ধরে ব্লাড লস হচ্ছে, কি কি কারণ হতে পারে? ডিইউবি, ডিসফাংশনাল ইউটেরাইন ব্লিডিং অ্যান্ড মেনোরেজিয়া, কোনো কোনো ক্ষেত্রে পাইলস, ব্লিডিং পাইলস সেগুলো। Next history we are going to, that is anemia during pregnancy. It may be due to deficiency of iron and folate. Patient iron এবং ফলিক অ্যাসিড আমরা প্রেসক্রাইব করি প্রেগন্যান্সির সময়, তার কারণ এই সময় নিউট্রিশনাল ডেফিসিয়েন্সি হয়। And very strange thing, an intense and abnormal desire to eat strange substances like earth, মাটি খায় পেশেন্ট অনেক সময়, এটাকে বলে পাইকাফাজি, is a peculiar feature of iron deficiency anemia. Iron deficiency anemia আছে এমন পেশেন্ট, এরা লুকিয়ে লুকিয়ে মাটি, চক, খড়ি এগুলো খায়, এটাকে পাইকা বলে, পাইকাফাজি। এটা পেশেন্টের খুব অদ্ভুত একটা প্রেজেন্টেশন, অনেক পেশেন্ট জিজ্ঞাসা করলে বলে মাটি খায়, এটা কিন্তু আয়রন ডেফিসিয়েন্সির একটা লক্ষণ, পাইকাফাজি। আর একটা জিনিস জানতে হয়, ক্রনিক অ্যালকোহলিজম আছে কিনা। ক্রনিক অ্যালকোহলিজম মে কজ ভিটামিন B12 অ্যান্ড ফোলেট ডেফিসিয়েন্সি। History of malabsorption syndrome such as celiac disease and tropical sprue causes combined deficiency of folate, vitamin B12 and iron. কারণ malabsorption হচ্ছে এটা ইন্টেস্টিন থেকে এই নিউট্রিয়েন্টস গুলো অ্যাবজর্বেশনই হচ্ছে না। অ্যাবজর্পশন যদি না হয় তাহলে সেটা একটা সময় গিয়ে কিন্তু ডেফিসিয়েন্সি অ্যানিমিয়া হিসাবে প্রেজেন্ট করবে। কাজেই আমাদেরকে জানতে হবে there is any history of malabsorption syndrome like celiac disease, tropical sprue etc. কিছু আছে কিনা। পরের অংশে যাচ্ছি, সেটা হলো ড্রাগ হিস্ট্রি। পেশেন্টের ড্রাগ হিস্ট্রিটা আমাদের নিতে হয়, কারণ there are so many drugs causing different types of anemias. So drug history tracking is very important part. Hypoplastic anemia caused by cytotoxic drugs like chloramphenicol and phenobutazone. megaloblastic anemia caused by methotrexate and anticonvulsants. Iron deficiency anemia caused by aspirin, কিভাবে করছে? by GI blood loss. And hemolytic anemia caused by antimalarials, penicillin, methyl dopa, etc. তাহলে আমরা পেশেন্ট এলে তার ড্রাগ হিস্ট্রিটাও নিয়ে নেবো। এই ওষুধগুলো যেগুলো বললাম, এই ড্রাগসগুলোর মধ্যে পেশেন্ট কোনোটা খাচ্ছে কিনা অনেক দিন ধরে, সেরকম কোনো হিস্ট্রি আছে কিনা আমাদেরকে জেনে নিতে হবে, কারণ few drugs causes several types of anemias. Chloramphenicol, phenobutazone, methotrexate, anticonvulsant, aspirin, penicillin, methyl dopa, malaria ড্রাগ খাচ্ছে কিনা, এই হিস্ট্রিগুলো আমাদেরকে নিয়ে নিতে হবে। ঠিক আছে, এই অবধি বোঝা গেছে? এরপরে আসি ল্যাবরেটরি ইভ্যালুয়েশন। ল্যাবরেটরি ইভ্যালুয়েশনে আমরা বেসিক কয়েকটা টেস্ট করি। বেসিক টেস্টের মধ্যে প্রথমেই আসে পেরিফেরাল ব্লাড স্মিয়ার, যেটার কথা আমি একদম প্রথমেই বলছিলাম। এই কম্পারিজনটা আমরা কিভাবে করি, মাইক্রোসাইটিক, ম্যাক্রোসাইটিক, নর্মোসাইটিক, এটা আমরা কোথায় দেখি? পেরিফেরাল ব্লাড। পেশেন্টের ব্লাড এক ফোঁটা নেওয়া হয়, 1 ড্রপ, একটা ব্লাড স্লাইডের ওপর, সেটাকে স্প্রেড করা হয়, সেটা হচ্ছে স্মিয়ার তৈরি হলো। এটা আলাদা ক্লাস হবে তোমাদের পেরিফেরাল ব্লাডের উপর, জন্য আমি খুব ডিটেলসে যাচ্ছি না। গিয়ে সেটাকে আমরা রোমানোভস্কি স্টেনে স্টেইন করি। লিশম্যান সাধারণত করা হয়, লিশম্যান স্টেন করে সেটাকে আমরা অয়েল, এক ফোঁটা অয়েল দিয়ে অয়েল ইমার্শনে যখন দেখছি, তখন আমরা আরবিসির স্ট্রাকচার এবং বাকি আরও যে জিনিসগুলো আছে, ডাব্লিউবিসি, আরবিসি, সব পরিষ্কার বোঝা যায়। এবং আরবিসির শেপ সেটাও আমি ডিটেলসে যাবো না, কারণ পেরিফেরাল ব্লাডের আলাদা ক্লাস হবে, ওটাতে বলা হবে। আরবিসির শেপ এবং সাইজ চেঞ্জ হচ্ছে, কিভাবে হচ্ছে, তার কি নাম আছে, এগুলো সব পেরিফেরাল স্মিয়ারে we can get a lot of information from the peripheral blood smear, which type of anemia, what kind of anemia, severity of anemia ইত্যাদি, এগুলো সব জানা যায়। ঠিক আছে, পরের অংশে আমরা চলে আসছি, সেটা হচ্ছে রেটিকুলোসাইট কাউন্ট। রেটিকুলোসাইট কি? রেটিকুলোসাইট হচ্ছে, প্রথমেই বলেছি, এটা হচ্ছে immature form of RBC. এটা young red cell containing RNA remnants and RNA stains with supravital dyes such as brilliant chisel blue. এটা হচ্ছে ইম্যাচিওর ফর্ম অফ আরবিসি, যেটার মধ্যে তখনও আরএনএ রেমন্যান্টটা রয়ে গেছে, যেটাকে আমরা স্টেন করে দেখতে পাই, ডট 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 মতো দেখায় কিছু আরএনএ রেমন্যান্টস। এবং এটা কিভাবে কাউন্ট করে? রেটিকুলোসাইট কাউন্টেড বাই নাম্বার অফ রেড সেল ইন্টু 100। এইভাবে আমরা মোটামুটি রেটিকুলোসাইটটা, এই একই পেরিফেরাল ব্লাড থেকেই কিন্তু আমরা রেটিকুলোসাইট কাউন্টও করতে পারি। রেটিকুলোসাইট কাউন্টের নর্মাল ভ্যালু হচ্ছে 0.5 to 2.5%, এবং এটার কম বেশি বিভিন্ন ধরনের অ্যানিমিয়ায় বিভিন্ন রকমভাবে এটা প্রেজেন্ট করে। কেন, কিভাবে হয়, সেটা অনেক ডিটেলসে, এটা লাগবে না, এটা তোমাদের পরে আলাদা করে প্র্যাকটিক্যাল ক্লাসে এগুলো হবে। আমি থিওরির জন্য শুধু নামগুলো মেনশন করেছি, কারণ থিওরিতে এতখানি বলতে গেলে তোমাদের লিখতে অসুবিধা হবে, পরীক্ষা এতটা লিখতেও পারবে না। ঠিক আছে, জাস্ট নামগুলো মেনশন করছি। আচ্ছা, রেটিকুলোসাইট, পেরিফেরাল ব্লাড স্মিয়ার গেল, তারপর হচ্ছে রেটিকুলোসাইট কাউন্ট, এবং থার্ড ওয়ান হচ্ছে ডিফারেন্ট টাইপ অফ রেড সেল ইন্ডিসেস, যেগুলো আমি বলছিলাম তখন, এমসিভি, এমসিএইচ, এমসিএইচসি, আরডিডব্লিউ, এইগুলো, এই রেড সেল ইন্ডিসেস, এইগুলো মোটামুটি 3টে বেসিক টেস্ট আছে, যেগুলো করে আমরা ল্যাবরেটরিতে অ্যানিমিয়ার জন্য একদম প্রাইমারি করি। পেরিফেরাল ব্লাড স্মিয়ার, রেটিকুলোসাইট কাউন্ট এবং ডিফারেন্ট টাইপ অফ রেড সেল ইন্ডিসেস। রেড সেল ইন্ডিসেসগুলো বেশিরভাগই এখন মেশিনে হয়ে যায়, হাতে এরকম করে করতে হয় না, এগুলো মেশিনে যে প্রিন্টেড চার্ট থাকে সেখানে আমরা পেয়ে যাই। Depending on the result of the studies, further specialized laboratory procedure may be carried out to arrive at a definitive diagnosis. এবার আমরা কারণের দিকে এগোচ্ছি, যে কেন অ্যানিমিয়াটা হয়েছে। অ্যানিমিয়া তো হয়েছে বোঝা গেল, এবার ডেফিনিটিভ ডায়াগনোসিস পাওয়ার জন্য আমাদের কতগুলো আরো টেস্ট আছে, জাস্ট নামগুলো জানলেই চলবে। একটা হচ্ছে বোন ম্যারো এক্সামিনেশন, দুই হচ্ছে সেরাম আয়রন। সেরাম আয়রন কতটা আছে সেটা আমরা এখান থেকে জানি। নাম্বার 2 হচ্ছে সি হচ্ছে টোটাল আয়রন বাইন্ডিং ক্যাপাসিটি, অ্যান্ড লাস্টলি হিমোগ্লোবিন ইলেকট্রোফোরেসিস। এগুলো সব স্পেশালাইজ টেস্ট, এগুলো করে আমরা ফাইনালি অ্যানিমিয়ার কি কারণ সেইটা অবধি পৌঁছাতে পারি। তাহলে বেসিক টেস্ট করলাম, তারপরে হচ্ছে এগুলো স্পেশালিস্ট টেস্ট, স্পেশালাইজ টেস্ট। ঠিক আছে, তাহলে অ্যানিমিয়ার ডেফিনেশন, ক্লাসিফিকেশন, তার কজ এবং অ্যাপ্রোচ টু ডায়াগনোসিস, এই ছিল আজকের টপিক। কারোর কোনো অসুবিধা থাকলে বা বোঝার অসুবিধা থাকলে আমাকে বলতে পারো, ঠিক আছে? এই পর্যন্তই আজকে।
First of all, what is pharmacodynamics? You have already had a class on pharmacokinetics. And pharmacokinetics, can anyone tell me what is pharmacokinetics? You have already had a class on pharmacokinetics. It was probably the previous class. What is pharmacokinetics? What the body does to the drug. So when a patient takes drug, there is interaction between the body and drug. Drug has entered into the body, so there is interaction between the body and the drug. So when the body enters, আমি ছাড়তে পারবো না বাবা, থাক তুই থাক, ভালো লাগে আমার খুব। When the drug enters the body, there is interaction between the drug and the body. Okay, so what happens? Something the body does to the drug, that is pharmacokinetics, and something the drug does to the body. Whatever the drug does to the body, that is how the drug is acting in the body. That is the mechanism of action of the drug, to say simply. And that is what is pharmacodynamics. So to understand it easily, pharmacodynamics is basically how the drug is acting in the body, the mechanism of the drug. Now, when a drug enters into the body, first it reaches blood, that is the systemic circulation. From there it goes to the site of action, the organ where it wants to act. And there, each drug has its own receptor. You have the concept of receptor already from physiology. So the drug binds to its receptor and exhibits its mechanism of action. And when the drug exhibits its mechanism of action, there is a clinical response. And that response can be an adverse effect, but we are looking mainly for the therapeutic effect. So there will be a therapeutic effect of the drug, the clinical effect of the drug. Apart from the clinical effect, some unwanted effects will also be there, which are the adverse effects. This is basically how the drug acts. Now, what are the principles of drug action? Basically, to understand this principle is that a disease process is going on inside the body. When you are taking drug, you are taking for a particular disease, to treat a particular disease. So a disease process is going on in the body. When you take the drug, it by various general mechanisms try to interrupt the disease process. Okay, try to interrupt the disease process. So how it tries to interrupt the disease process? First is stimulation. Stimulation, like suppose adrenaline. When you give a patient adrenaline in certain conditions, that adrenaline stimulates heart. So adrenaline is stimulating. Mechanism by which the drug here is interrupting the disease process is stimulation of a particular cell, stimulation of heart, cardiac cells. Then depression. A drug can also depress specialized cells in the body. Like there is a group of drug called barbiturates which depress the CNS. All of you suffer, not all of you, many of you must suffer from hyperacidity, gastric disorder, right? Gastric acid disorder. For those patients, there is one common group of drugs we use called proton pump inhibitors. One of the examples of proton pump inhibitor is omeprazole. And this group of drugs, omeprazole, they decrease secretion of gastric acid. Thus, they suppress or depress the cells producing gastric acid. So, stimulation, depression. Then you have irritation. You know, some of you might have used something called Volini. Have you used? You have got hurt somewhere in the body and you apply a ointment, and following application of that ointment, first there is a burning sensation. That burning sensation is followed by relief of pain. So first what happens, the drug that mainly acts in that way in Volini is called capsaicin. Okay, also methyl salicylate. These drugs cause irritation on the skin, and because of that irritation, underlying pain is relieved. Okay, that is called gate theory. We will take it up later on, but just to tell you. Then a drug can act by replacement. best example is not written in the slide. All of you must have heard about thyroid disorder, that patients take one thyroid hormone tablet early morning in empty stomach. Okay. So thyroid hormone is not being produced in their body properly. So you have to replace it from outside. Here the drug is replacing. Alright. Then cytotoxic action. Cytotoxic action is the drug is killing some cells. Which cells? Which cells? Invading parasites. Yes, yes. Invading parasitic cells or cancer cells that are damaging the body. They are killing those cells. Now, mechanism of drug action. How a drug acts. Just to say in a general way how a drug acts. A drug can act by the virtue of its physical and chemical property. A drug can also act by interacting with certain biomolecules like enzymes, ion channels, transporters and receptors. By virtue of its physical and chemical property, how can a drug act? Example, isabgol. Many of you might have taken or have seen people taking isabgol. It is a laxative that softens up stool and relieves constipation. Isabgol, when you take isabgol, it absorbs water. It swells up in the GI tract and increases peristalsis. So here, by the virtue of its physical property of absorbing water and swelling up, isabgol is acting. Okay, so this is an example of how by virtue of its physical property a drug can act. By virtue of its chemical property, you have taken antacids for having acid like liquid antacids like gelocil, polycrol, diazine. You have heard the names, might have taken also. They are all alkalis, bases. When you take them, they simply go and chemically neutralize the excess acid that has been formed inside your gastrointestinal tract, to be more precise, inside the stomach. Okay. So these are few examples. There are other examples. A drug can also act by interacting. So this is by the virtue of physical and chemical property how a drug acts. A drug can also act by interacting with target biomolecules. Like a drug can induce an enzyme or it can inhibit an enzyme. A drug acting by enzyme induction is not very common. There are some examples given here. But drug acting by enzyme inhibition is rampant. When one by one you will study the various systems, you will see that there are many drugs who exhibit their clinical effects simply by the virtue of inhibiting various enzymes. They inhibit various enzymes in our body and thus they disrupt the ongoing disease process. Okay, something wrong is happening inside the body. Our body enzymes are responsible and taking part in that pathological process. The drug goes and inhibits that enzyme and helps to reverse that pathological process. Okay, that is enzyme inhibition. You have studied in biochemistry, I think there can be various types of enzyme inhibition: reversible, irreversible, and reversible, irreversible are called competitive, and there also can be non-competitive inhibition. Basically, at this level, if you can remember the examples, it will be fine. Just to remind you that in competitive inhibition, what happens? This is the binding site of the drug as well as this is the binding site of the drug. This is the enzyme. This is the binding site of the substrate and a competitive inhibitor. The drug will come and inhibit this enzyme in such a way that there is reversible inhibition. So this is basically the substrate and this is the competitive inhibitor. So this competitive inhibitor is basically the drug in our case. The drug will compete with the substrate and bind with this enzyme and inhibit this enzyme. If this is a reversible inhibition, then if you increase the substrate concentration, then the substrate can displace the drug and it can again, the disease process can again continue. The example of a reversible inhibition is physostigmine inhibits cholinesterase. Only when you study cholinergic system you will understand this. Now for the purpose of remembering, you can just remember that an example of a drug causing reversible competitive inhibition is physostigmine inhibiting cholinesterase, where if the concentration increases, then the inhibitor can be displaced again. But there can also be irreversible inhibition where the drug binds covalently and just by increasing the substrate concentration, the drug cannot be displaced. Example, organophosphorus poisoning or organophosphates inhibiting cholinesterase. Similarly, there can be non-competitive inhibition. Example, aspirin inhibits enzyme cyclooxygenase. In non-competitive inhibition, there is a different site. Here in competitive, in the same site, the drug binds. Here in a different site of the enzyme, the drug binds and it alters the function of the enzyme so that the enzyme cannot act. So these are the old concepts. We have to mainly remember the examples. Now drugs can also interact with various ion channels to exhibit their actions. Just remember the example of quinidine. It's an anti-malarial drug as well as an anti-arrhythmic drug. Anti-arrhythmic drug means it is used for treatment of cardiac arrhythmias, irregular heart rate. Quinidine blocks sodium channels. And there is another drug called nifedipine, which was used quite commonly, not so much nowadays, as an antihypertensive and anti-anginal drug. It blocks calcium channels. Drugs interact with transporters. You have to just remember the example, like desipramine is a drug that blocks uptake of noradrenaline. So it is basically blocking the transporter of noradrenaline. Similarly, drugs interact with receptors to give their effects. This drug receptor interaction is very important, and there will be a separate class on this drug receptor interaction. There are various aspects of this drug receptor interaction: agonism, antagonism, all right. Then what are the different types of receptors that drugs bind to? You have already studied some of them in biochemistry, like G protein coupled receptors. Okay, that will be a separate class. Now we move on to our next topic called the dose response relationship. This is a curve. This is a curve. As you can see, it's a hyperbolic curve. It is called the dose response curve. What is it actually? Here, many patients are given different doses of a drug, and the response of that drug in those patients are recorded. And the different doses and their corresponding responses are plotted in a curve. And when we do that, we get this curve, which is called the dose response curve. It is called the dose response curve, and it is a hyperbolic curve. What is the importance of dose response curve? We'll come to it. From the dose response curve, we get a lot of information about the drug. But before that, you see, instead of taking the dose of the drug, if you plot log dose of the drug against response, then this dose response curve becomes a log dose response curve. And the shape of the curve from an hyperbola becomes a sigmoid shaped. This sigmoid shape, when it becomes sigmoid shape, what happens is that within a small area, lot of readings can be taken. Lot of values can be plotted. Compared to hyperbolic curve, in a sigmoid curve, within a small area, lot of readings can be taken, or lot of values can be plotted. More importantly, in a sigmoid shaped curve, you see the middle portion, this part to this part, a middle portion is a straight line. And when you have a straight line, it is much more easy to calculate various characteristics or various points and values related to the drug. A straight line helps us to calculate various aspects of the drug. Alright, so when you convert dose response to log dose response curve, lot of values can be plotted within a small area, because simply you are taking log dose, and here you get a straight line, and in that straight line it is very easy compared to a hyperbola. It is very easy in a straight line to do various mathematical calculations and find out various parameters. Now, what informations we get from a dose response curve? First is the drug potency. What is actually drug potency? Drug potency, see, when you are plotting dose of the drug on x-axis and response on y-axis, you are getting a sigmoid shaped curve. Now, beyond the point, you are increasing dose and the response is increasing gradually. But beyond the point, even if you increase the dose, response will not increase. See, it has become stationary at the upper level. This is the upper level. It is not increasing further. At one point, the response is finished. So, this is the maximum response. You can go on increasing the dose, but you will see that in spite of increasing the dose to whatever level you want, clinical response will stop here. So, this is the maximum response. 50% of that maximum response can also be seen from this curve. 50% of this maximum response. Now, the dose of the drug that produces 50% of the maximum response. See, this is the dose which is producing 50% response. This is the dose. When you go up from here and then to here, you get 50%. So, the dose of the drug that is producing 50% of response is actually the potency. The amount of drug or the dose of drug that produces 50% of maximum response is the potency. And why it is important? It is important because we can compare two drugs, their comparative potencies from here, and moreover, when we know the potency of the drug, we can determine the dose of the drug. That is, to treat a particular condition, how much dose is to be needed. That idea we can get from potency. Okay. So, this is the potency, 50% of maximum response. If potency is 50% of maximum response, the maximum response of a drug is itself called efficacy. And this is the most important, or rather not, if I don't say most, I can say it is one of the most important parameters of a drug, that is called efficacy, which is the maximum response that can be produced by a drug. No matter how much dose you increase, it will not cross this level. This is the maximum response. All right. Next, so from a dose response curve, we can see potency, we can see drug efficacy. Similarly, we can also see the slope of the curve. You see, here are two dose response curves. Here are two dose response curves. One curve is steep and the other curve is flat. What does that mean? This means that for this drug, when you increase the dose slightly, there is a lot of increase in response. But for the lower one, when you increase the dose slightly, there is only a slight increase in response. So, a steeper slope of the dose response curve indicates that a small change in dose can have a lot of clinical effect. That idea we can get from this dose response curve. All right. That idea we can get from dose response curve. Now, this is an important concept, that therapeutic index. What is therapeutic index? See, this is a dose response curve. The first one, a dose response curve, log dose response curve. Again, you see another dose response curve, but the second dose response curve, the second is the therapeutic effect. You have a dose response curve here and another dose response curve. In the second dose response curve, we have not seen the therapeutic effect. We have seen adverse effect. So, we have plotted adverse effect, a curve with adverse effect and a curve with therapeutic effect. All right. And you see the same drug, the same drug, when you increase the dose, is giving adverse effect. At a lower dose, it is giving therapeutic effect. So this gap between these two curves, just to remember it, this gap is called the therapeutic index. Means it is a safety margin. When you increase the dose from here to here, adverse effects become prominent. So this is a safety margin. How do you calculate this safety margin? That is called therapeutic index. It is the dose that produce toxic effect. See, this is the curve for therapeutic effect and this is the curve for adverse effect. Alright. Again, you have the concept of potency, that is 50% of maximum response. In this curve, you look for 50% of maximum response. That is the dose of the drug that is producing 50% of max. One more thing, when you are looking at this dose response curve, remember in the y-axis, instead of response, here we have plotted the percentage of patients showing response. Percentage of patients showing response. So with this dose, you see that 50% of patients in this dose, this is the dose, 50% of patients are showing response. And now if you go to the adverse effect curve, you see with this dose, 50% of patients are showing adverse effect or toxicity, whatever you call. So from this curve, this is called TD50. This is 50%, this is the dose that produces adverse effect in 50% of patients. Here we have plotted percentage of patients showing therapeutic effect and percentage of patients showing adverse effect with the corresponding doses. So the dose that is producing therapeutic effect in 50% of patients, and this is the dose that is producing adverse effect in 50% of patients or toxic effect in 50% of patients. Now, to calculate therapeutic index, we put TD50, that is the dose that produce toxic effect in 50% of patients on numerator, and ED50, that is the dose that produce therapeutic effect in 50% of patients in the denominator. And their ratio is called the therapeutic index. Higher the therapeutic index, safer is the drug for human consumption. Alright, higher the therapeutic index, safer for human consumption. You have to remember, you will be asked the definition of therapeutic index, you have to tell this definition, ratio of this, and how you calculate. You take a dose and you see 50% of patients having therapeutic effect and 50% of patients having adverse effect, and their ratio is this. Larger the index, safer is the drug. And examples of drugs with narrow therapeutic index, this will be asked in the viva. Some drugs with narrow therapeutic index, so some unsafe drugs. They are example of some unsafe drugs. Phenytoin, carbamazepine, they are all anticonvulsants. Valproic acid, digoxin, lithium, theophylline, warfarin. You have to remember these examples. Now, this is therapeutic index in human beings. There is another thing called pharmacological therapeutic index. While doing animal experiments, we also want to find out that what dose is producing death in animals. We cannot do that in humans. We cannot give that high dose in humans that death will occur. But in animals, we do try and find out the lethal dose. And we see that how much of the drug is lethal. In that case, you have a therapeutic curve, you have a toxic effect curve, and then you have a lethal effect curve. Alright, so dose is further increased from toxic level to a level where the animal dies. This is done only for animals. And pharmacological therapeutic index, here we take the dose in the numerator that is producing death in 50% of animals. And below we take the dose that is producing response in therapeutic response in 50% of animals. And there we make the ratio. This is another concept called therapeutic window. Therapeutic window, what happens is that you give a patient a drug and you plot the concentration of that drug on y-axis against time on x-axis. You see how the drug level gradually rises in the blood of the patient. And what you see is that first the drug level rises up to a certain point, and then the gradually drug level falls due to metabolism and other things that you know, ADME, absorption, then distribution, metabolism, elimination. So first drug level rises and then drug level falls. This is called the plasma concentration time curve. Now one has plasma concentration of drug, and here is the time in x-axis. You see the drug level reaches a maximum point and then starts to fall. If a patient is given excess of that drug, this happens when you give a therapeutic level, when you give drug at therapeutic level that the patient should be given. But if you give excess dose of the drug, this can further go up. This can further go up and reach the toxic level. So to calculate safety, what we do is that we take two lines and we calculate the space between these two lines. What are these two lines? This is called the minimum effective therapeutic concentration. Minimum effective therapeutic concentration is nothing but, here you have been given the definition that it is the dose of the drug that provides safe and effective therapy with minimal adverse effect. At this level, you get safe, effective therapy with minimal adverse effect. And at this level, it is the dose of the drug that extends from minimum effective, this is the minimum toxic concentration. This level is called the minimum toxic concentration. At this level, you get adverse effects that can be maximally accepted. Beyond that, there will be chance of severe toxicity and death. So maximum accepted adverse effect is here, and this is the minimum effective therapeutic concentration. Minimum effective therapeutic concentration, minimum toxic concentration. The gap between minimum toxic concentration and minimum effective concentration is the therapeutic window. Higher this gap, safer is the drug. There are drugs that have low therapeutic window like phenytoin, digoxin and lithium. Phenytoin, digoxin and lithium. These drugs, for these drugs you have to do therapeutic drug monitoring. For these drugs you have to do therapeutic drug monitoring. Alright, now what happens when two drugs are combined? When two drugs are combined, first of all, there can be no pharmacological interaction between them, or there can be synergism as well as antagonism. Synergism is one drug helps the other drug. One drug helps in functioning of the other drug, that is synergism. And antagonism is one drug will prevent the action of another drug. So there can be no effect when two drugs are taken together, or one drug might help another drug, or one drug might inhibit the function of another drug. Synergism has two things. One is additive and the other is supraadditive. Additive means two drugs taken together, effect of one drug just adds on to effect of another drug. Alright, 1 plus 1 equals to 2. Like suppose amlodipine is an antihypertensive, atenolol is an antihypertensive. When you take them together, there is an additive effect. Both of them acts together and help in good control of hypertension. But there is another case which is called supraadditive, where effect of one drug actually increases the effect of another drug. The best example is, look at the third example, sulfamethoxazole and trimethoprim. These are two antibiotics that are taken together in combination, sulfamethoxazole, trimethoprim. Sulfamethoxazole alone and trimethoprim alone when given, their effect, if you add up, when they are taken together, their effect is much more. If you give only trimethoprim, whatever effect there is, if you give only sulfamethoxazole, whatever effect there is, if you give them together, their effect is much more, because one helps the other in various ways. When you will study antibiotic, you will have this topic, sulfamethoxazole trimethoprim combination. How this combination has a very good effect, how one drug helps the other. But this is an example. Antagonism is simply one drug is reducing the action of another drug. That is antagonism. Antagonism can be physical antagonism, like charcoal is used in alkaloid poisoning. Simply you give charcoal in the GI tract and it absorbs alkaloids. Or it can be chemical antagonism, or it can be physiological or functional antagonism. Physiological or functional antagonism means action of one drug alters the physiological effect of another. So that, like, see, glucagon and insulin. Insulin is a drug that reduces blood sugar level, and glucagon is a drug that increases blood sugar level. So if there two of them are given together, effect of one drug will neutralize partially or completely the effect of another. So you will get effect of none. This is called physiological antagonism. Now, factors modifying drug action. You see, two patients taking the same drug, the drug will not have same effect on both the patients. There will be different effect on both the patients. Okay. So, why this happens? This happens because there is difference in absorption, distribution, metabolism and elimination in each patient. Each patient is a unique model. So, in each patient, the absorption, the distribution, the metabolism, elimination of drug will be different. Also, the receptors, their number, their state, whether they are active or inactive, the various pathways that are involved along with receptors, their functions, that also vary from patient to patient. That's why the same drug does not produce same effect in all the patients. It varies. Effect of drug varies from patient to patient. Now, there are certain factors which we should look into when we determine how a drug's action varies. First is body size. Higher body size, usually we need higher dose of the drug. Okay, we have a standard adult dose, but generally these things have to be remembered, that a higher body size means a higher dose of the drug. Exceptionally obese or exceptionally lean patients, we need to do dose modification. We need to change their dose from an average dose. And this is the equation by which we do that. Then age. You see, the children and the elderly are given lower doses compared to adults. Why? Because in children, the various systems are developing so that metabolism is much slow. The same drug takes much more time to metabolize. As a result, children needs lower dose than adults. And again, when you go to elderly population, there the systems stop functioning gradually. Kidney, liver, their functions gradually decrease. So the drugs also tend to accumulate there. So again, in elderly, we have to give lower dose of the drug. In children, we often use body weight, per milligram body weight as an approach of fixing dose. Like in adult, we have suppose 500 milligram of tablet to be taken thrice daily. In children, we don't say like that. We give suppose 10 milligram per kg, because in children the weight varies so much that in accordance to the body weight, the dose is to be fixed. And in elderly, you know what we do? In elderly, we reduce dose according to renal function, hepatic function, etc. These are done. Then sex, not so important, but mainly remember in females during pregnancy and lactation. Females have smaller body size, this is a general thing to say, but in pregnancy and lactation, lot of dose modifications is required which are not required in males. Again, there are some drugs that cause gynecomastia in males, that is abnormal breast tissue formation, which is not a side effect in females. So there are some difference in relation to sex also when we see factors, when you see effect of drug. Species is very important. In some species, some drugs act more, and in some species, some drugs act less. Like rabbits. In rabbits, atropine, there is a drug called atropine, which has lot of uses. We will study about it in anticholinergic chapter. that atropine acts much less in rabbits. It is resistant in rabbits. Similarly, even if you look into human race, in the human population, according to race, there is variation. Like the same atropine needs a higher dose in the blacks, in the Africans, and a lower dose in the Mongols. Now, genetics, there are certain genetic peculiarities due to which drug action varies. Like, very important, some population have an enzyme deficiency called G6PD deficiency, glucose 6-phosphatase deficiency. If there is this G6PD deficiency, some drugs cannot be given to these patients, because when these drugs are given, there are side effects. There are side effects like hemolysis, and that hemolysis may lead to other multi-organ failure. Okay, so genetics also modifies drug action. Then routes of administration, whether you give a drug by oral route or by some other route, that also alters drug's action. As an example, magnesium sulfate is a drug which when given orally acts as a laxative, or rather as a strong purgative. Strong laxatives are called purgatives. It acts as a purgative. But when it is given on the skin, it reduces inflammation. And when it is given IV, it causes CNS depression. It reduces seizures. Then various diseases also alter drug effect. In kidney disease, lot of drugs that are eliminated by kidney from the body, they gets accumulated. So you have to give lower doses. All right. Then there is a term called tolerance. What is tolerance? Tolerance is, as you continue to give drug to a patient, the effect of the drug in that patient gradually decreases. That is called tolerance. All right. So tolerance also develops, and some animals are more tolerant to a drug compared to human beings, like rabbits are more tolerant to atropine. Now, tolerance can be of two types. One is acquired tolerance. Acquired tolerance is when you give a drug, just what now I said, when you give a drug continuously, its responsiveness gradually reduces. That is acquired tolerance. Example, acquired tolerance develops to a drug called chlorpromazine. It's an antipsychotic drug. Okay, used in treatment of psychiatric disorders. It has sedative side effect. That effect gradually reduces as you go on taking the drug or go on giving the drug to a patient. Similarly, there is another analgesic called morphine. It reduces pain, but that pain reducing action also gradually reduces if you continue giving patient that drug. So this is called tolerance. You continue to give a drug to a patient, that effect of the drug in that patient will gradually decrease. Tolerance. Cross tolerance is because you have given one drug, another drug that is similar to it also will exhibit less effect. That is called cross tolerance. Like alcoholics respond less to general anesthetics. Alcohol is a CNS depressant. So those who are addicted to alcohol, when you are giving anesthesia to them, you need higher doses of general anesthetics because their brain is already set in such a way that they can tolerate a CNS depressant. You have to give a higher level of CNS depressant to make that patient unconscious. Next, adverse drug reactions. Adverse drug reactions, there is a WHO definition of adverse drug reaction. We are not going to definition, you can read it. Simply as the name suggests, adverse drug reactions means a drug having some adverse effects that are not acceptable. Now, they can be of various types. A to F. A is augmented. One by one, we will deal with them. Let's go there. A, augmented. What does an augmented adverse effect mean? Augmented adverse effect mean that you give drug to a patient, there is some adverse effect. No, you give drug to a patient first, there is no adverse effect. Now you gradually increase the dose of the drug, gradually adverse effects come. They are predictable. You give low dose, there is no adverse effect. You gradually increase the dose, adverse effects start coming. So they are predictable and they are very common. Okay, suppose taking in low dose, there will be no adverse effect. But when you increase the dose, there will be GI irritation, gastric irritation and abdominal pain. So as you go on increasing the dose, there will be more adverse effect. That is why it is called augmented, type A. As you increase the dose, the adverse effects come. They are common type, and they can be classified into 3 types. One is the side effect, that we commonly say side effect of a drug. Undesirable, unavoidable things. You have to treat a patient with a certain drug, you have to accept certain side effects. It is like that. At therapeutic dose, to get the clinical effect, there will also be some side effects and you have to accept them. Like, suppose you are giving an antihypertensive. That antihypertensive will reduce blood pressure, but at the same time will cause mild dizziness. Means there will be a sensation of rotation around, dizziness, okay? Or there may be mild fainting, there will be dark spots in front of the eye. The eye might turn dark. These are common side effects. It happens when you start a new drug, gradually it goes away. So these you have to accept. These are side effects. So under augmented you have side effects. Then here you have given a common example that if you have seen that sometimes even in the Hindi movies earlier it used to say that if there is a heart attack, someone will put a tablet beneath the tongue. Have you seen? These are called sorbitrate. So sorbitrate has a common side effect, happens in most of the patients, very severe headache in the first week of therapy. It goes away, but you have to accept that. So side effects occur at therapeutic doses. But there are another thing called secondary effect. Secondary effect means the drug itself is not directly causing any side effect. But due to that drug, another disease process starts happening actively in the body. Like suppose you are giving steroid to a patient. Steroid are a group of drugs that cause immunosuppression. They reduce immunity in a patient. Okay. As a result, that patient had latent tuberculosis. Tuberculosis or TB was there in the body of the patient in a sleeping state. But because immunity has been reduced, the tuberculosis become active. So directly steroid has not caused tuberculosis. It was already there, but because steroid has reduced the immunity level, now tuberculosis has become active. This is called secondary effect. Then there can be toxic effects. Toxic effects means when you give drug for a prolonged period or a very high dose, there will be some toxic effect. This is not side effect. Side effect is when you give a therapeutic dose, you get some undesirable things. Toxic effect means when you are giving at very high dose, okay, which are not acceptable. Next is B. So side effect A is gone, augmented. B is bizarre. Bizarre side effect means in general patients do not occur. Okay, occur in selective patients because of some variation in the patient's body. All the patients will not have bizarre side effects. Some patients are predisposed because of the uniqueness in their body to have certain unexpected side effects. So these are not expected. While augmented side effects type A you can expect to happen, you can be ready, but this can happen suddenly out of expectation. So they are more dangerous and they can be very serious. They include intolerance, hypersensitivity and idiosyncrasy. Intolerance means suppose there is a drug for treating diabetes called metformin. All the diabetic patients take metformin. It is the first line drug, it has to be given and then we do add on. But sometimes there are some patients who cannot take metformin. Even the lowest possible dose they cannot take because of gastric irritation. Alright, this happens. There are some drugs which in some patients at a very low dose produce side effect that are unacceptable. This is not normal. These patients are intolerant to that drug. So this is an unexpected thing that is happening. These are called intolerance. Alright, low threshold of side effect. You know chloroquine is used to treat malaria. Some patients with a single dose of chloroquine. Some patients are taking 4 tablets together, they can tolerate it. But some patients with a single tablet will develop severe side effects. So they are intolerant to a particular drug. So intolerance. Then comes immunological, then comes this hypersensitivity, drug allergy. Again, drug allergy will not occur in all patients. Only in some patients who are predisposed to have allergy to that drug, will suffer from it. So that is drug allergy. Again, you have studied it, I think, in physiology. There are 4 types: type 1, type 2, type 3 and type 4. And there are examples. What are they? I am not going into detail. You can go through the slides. You can take it from me, no problem. And you can go through the slides, okay? Just remember the examples. And this is important, idiosyncrasy. It is the of the unexpected side effects. This is the most unexpected, idiosyncrasy. Suddenly, in very selective patients, these side effects occur, or rather these adverse effects occur. Okay, so they are completely unexpected, unpredictable, like in quinidine. In some patients, suddenly cause cramp, diarrhea, asthma, vascular collapse. Barbiturates in some patients cause, and even at a low dose, tremendous excitement and mental confusion. Okay, these are barbiturates is an anticonvulsant used in seizure disorder. So you have to remember idiosyncrasy. The definition: it's a genetically determined abnormal reactivity to a chemical. So there is some specific gene defect in a patient due to which it reacts very violently to a drug. There is a sudden extreme side effect that is absolutely unexpected in general population. All right. Even those patients who have G6PD deficiency, they show idiosyncrasy to certain drugs. Suddenly they will develop severe hemolytic anemias, severe anemia. All right. Because the blood cells, RBCs, will break down. Okay. So we have A, B, C. Next is C, type C, chronic continuous. When some drugs are continuously used for long term, they can exhibit some adverse effect. That is the type C adverse effect, chronic continuous. Example, if you give steroids, there are a group of drugs, you will read about them later on. Very useful, but if used judiciously, if you give steroids continuously, a lot of side effects occur in the body. Short term it's okay, but continuously lot of side effects occur in the body. One such side effect is suppression of the hypothalamo-pituitary axis. Then type D is delayed. That is, you have given the drug and many years after giving the drug, the side effect starts. Or many months after giving the drug, the side effects starts. Example, teratogenicity. The mother has taken a drug in early pregnancy and later on when the child is born, they show a lot of abnormalities. There was a disaster called thalidomide disaster, a drug, you will read about them under pharmacovigilance. Thalidomide disaster, a drug that had caused congenital anomalies in children. Okay. So this is called teratogenicity. And another thing under delayed reaction is carcinogenicity. Some drug has been given to a patient and many years after that, due to that drug, the patient develops cancer. So it's a delayed side effect. Okay, example is cyclophosphamide causing bladder cancer. Type E is end of treatment. When you suddenly stop some treatments, there can be some adverse effects. Otherwise, the adverse effect do not occur. Suddenly stop treatment, there is an adverse effect. That is called end of treatment. Example, if you suddenly stop steroid, there is adrenal insufficiency. Failure of therapy, this is one drug is causing failure of another drug. So that's an adverse effect of the drug. Okay, failure of drug by various mechanisms. This is called drug dependence. What is drug dependence? I told you if you repeatedly give the same drug to a patient, tolerance develops. That is, the effect of the drug in the patient reduces, tolerance. So if you are giving 5 milligram and getting an effect, next time, not next time, after few months or a year, you will see that 5 milligram is giving lesser response. You have to give more drug, more maybe 10 milligram. So the patient is gradually developing tolerance. But what happens is that when this tolerance becomes too high, the body, what happens is that when you give an addictive drug, a drug to which there is chance of addiction, nesha hoye jawar chance thakche. When you are giving an addictive drug, first tolerance will develop and then dependence develops. That means the low dose of the drug will not help the patient will go on increasing the dose to get the same level, and gradually the patients become dependent on it. Without that drug, the patient cannot do. Dependence, এটাকে নেশা হয়ে যাওয়া বলে. Okay? Because of tolerance, the dose gradually increases and ultimately the patients become totally dependent on the drug. They cannot normally function without it. Dependence can be both physical as well as psychological dependence. That is, without the drug, there will be tremendous physical symptoms. We call it physical dependence. And without that drug, there will be no physical problem, but there will be tremendous mental distress. We call it psychological dependence. Psychological dependence is very common with cocaine. Cocaine causes no physical problem if you leave it, but there will be tremendous psychological problems. Okay? And if physical dependence happens with, suppose, arekta neshar jinish you must have heard, heroin. Heroin is a congener of morphine, an opioid. If someone gets addicted to heroin and leaves heroin, there will be tremendous mental as well as physical problems. That is physical distress. So heroin, remember, physical dependence, and only psychological dependence is cocaine. Tachyphylaxis. What is tachyphylaxis? Tachyphylaxis is rapid tolerance. I told you, you give a drug to a patient, after a few months or a year, the same dose of the drug is not producing desired effect. But in case of tachyphylaxis, what happens? You give drug to a patient, immediately in the second dose, you see the response comes down. In the third dose, you see the response further comes down. Okay? This happens in some special cases where there is rapid development of tolerance, and that is called tachyphylaxis. Example is, classical example, lot of examples are given, but classical example you should remember for tachyphylaxis is ephedrine. Ephedrine is a sympathomimetic drug. What it does is that, in case of ephedrine, noradrenaline that is synthesized in the nerve endings, adrenergic nerve endings, noradrenaline, ephedrine goes and displaces some noradrenaline from the nerve endings. Ephedrine goes and displaces some noradrenaline from the nerve endings. Now again, if you give ephedrine, the amount of noradrenaline available is very low. Noradrenaline synthesis is not that fast. So again, if you give ephedrine, noradrenaline is not available. So clinical response comes down. All right. So remember tachyphylaxis, remember the example ephedrine, and remember that it is rapid development of acquired tolerance. You give dose, one dose, and you repeat the dose immediately, you see the response rapidly comes down. Rapid decrease in response after its repeated administration. All right.
Okay. Amyloid, what is amyloid? Amyloid is an extracellular protein produced by the mutation of various globin chain or polypeptide chain in our body that may be normal protein overproduction or abnormal protein or mutant protein normal production. তো থিওরিতে আমি আজকে খুব বেশি যাব না, ঠিক আছে? এক্সট্রাসেলুলার ইনসলিউবল, এইটুকুন ইম্পর্টেন্ট। আচ্ছা, এটা ইলেকট্রন মাইক্রোস্কোপিক ফিচার। অ্যামাইলয়েডের যে প্রোটিন, অ্যামাইলয়েড হচ্ছে একটা পলিপেপটাইড চেন যেটা মনোমার বা মনোপেপটাইড দিয়ে যুক্ত থাকে। অনেকগুলো মনোপেপটাইড নিয়ে একটা পলিপেপটাইড হয় জানি। তাহলে এরকম মনোপেপটাইডগুলো বা ফিব্রিলসগুলো কিরকম করে অ্যারেঞ্জ থাকে সেইটা হচ্ছে এখানে দেখা যাচ্ছে ইলেকট্রন মাইক্রোস্কোপিক ছবি। আমরা কি কি প্রপার্টি দেখতে পাচ্ছি? ইনসলিউবল, লিনিয়ার, রিজিড, 7 to 10 ন্যানোমিটার ডায়ামিটার, সেটা লাইট মাইক্রোস্কোপে দেখা যায় না, তার জন্য দেখতে হবে আমাদের ইলেকট্রন মাইক্রোস্কোপে। But the fibrils are arranged in random array and are non-branching. There is no branching, and that is the random orientation. এই যে random orientation fibrils. Okay. Chemical properties, it will be taught on tomorrow. Amyloidosis. So localized and systemic, two types of amyloidosis. Systemic means, from the common sense, it involves the entire body, multiple organs. Okay. Localized, what is localized? Localized means it is confined, the disease process is confined to a single organ. Okay. So, what are the common sites of occurrence or the organs affected in primary amyloidosis, secondary amyloidosis? Okay, heart, GI tract, respiratory organs, peripheral nerves, these are all the predominantly affected organ in primary amyloidosis. But in secondary amyloidosis, that is the commoner form, that is present in kidney, liver, spleen, thyroid, lymph node. Kidney, liver, spleen and heart and brain are most commonly affected 5 organs in our body that have been affected by primary amyloidosis or secondary amyloidosis. Okay, so now coming to the first organ. Okay, this is the viscera you are familiar with. Okay, this is kidney, bean shaped kidney, right or left, that I don't know, but this is a bean shaped kidney. This is not normal kidney. Okay, this is a kidney affected in amyloidosis. Okay, this is most common and serious form, maybe normal sized, but this is enlarged kidney and shiny appearance, shiny glossy appearance. Okay, so but in advanced case, kidney size may be shrunken due to ischemia, due to low blood supply or diminished blood supply or hypoperfusion of the kidney. In advanced stage of amyloidosis, the kidney might be shrunken, but in general it is grossly enlarged. Okay, and now the cut section, pale, waxy and translucent. This is the serosal surface, this is the visceral surface, and this is the cut section. This is cortex, this is medulla. So cut section is pale, waxy and translucent. So the glistening structure, the glistening thing reminds me, or reminds the author as a wax. So that is waxy appearance. Okay, and it is the microscopically picture. So this is gross picture and this is microscopic picture. What is the microscopic picture is depicting over here? That is amyloid deposit or extracellular eosinophilic irregular deposits around glomerular basement membrane. That is not within the cell but in the interstitium. That is around the glomerular basement membrane, the GBM. There is extracellular deposition in glomerular, but arteries, arterioles and peritubular tissues are also affected, but mostly near to the basement membrane or glomerular basement membrane, where the amyloid tends to deposit more commonly. So now the next organ, amyloidosis of spleen. This is the gross picture or macroscopic view. Gross picture, macroscopic view. Okay, here we don't get any microscopic picture perhaps. No. So this is very important for MCQ point of purpose. Sago spleen or shagu spleen, jara banglaয় সাবুদানা, এই যে মা বাবারা ঠাকুমা দিদিমারা খায় বা ওনারা খান, সামার দানা বা সাবু, এই রকম দেখতে অ্যাপিয়ারেন্স, ঠিক আছে? তো দ্য গ্রসলি এটা sago spleen. 2 pattern of deposition are there in spleen. That is, one is sago spleen or shagu spleen, another is Lardachia spleen. Okay, sago spleen, from the name, from the common sense, what we can get, what we can interpret, that the outer surface of the spleen is appeared like a sago or small whitish studded structure. You can see gross appearance, moderately enlarged spleen dotted with gray nodules, white to gray nodules. Okay, this nodule, this is nodule, white and gray nodules of various sizes. They are deposited all over the spleen. This is cortex, this is medulla part, the vascular entry part and exit part. So the entire spleen is studded with gray to whitish nodules. Okay, so this is sago spleen. So what the amyloid deposits in sago spleen? In splenic follicles. This is a lymphoid organ, so it contains follicles, lymphoid follicles. So in sago spleen, amyloid tends to deposit in follicles, splenic follicles, resulting in gross appearance of moderately enlarged spleen. Lardachia spleen, and another pattern is Lardachia spleen. The amyloid deposits in subcapsular sinus. Okay, within the capsule, the vascular sinus, the vascular framework, the amyloid tends to deposit over there in Lardachia spleen. Wall of splenic sinuses and connective tissue framework in the red pulp. Okay, map like areas in amyloidosis. Lardachia spleen, amyloid ta jomech, like geographical distribution around the boundary border. Okay, everybody. So going to the next slide. চলে এসেছি না আমি, আমাকে একটু বলে দেবেন কখন আমি ক্যামেরার সামনে চলে আসি, অবস্টাকেল করি। অ্যামাইলোইডোসিস, এটা কি অর্গান? হ্যাঁ, লিভার, জোরে বলতে হবে। সো ইন লিভার, সেম grossly enlarged due to deposition of protein. The dry weight of the organ is increased. So any organ affected with amyloidosis is grossly enlarged and heavier in size than the normal counterpart. Okay. So organ enlargement, pale and rubbery form, waxy deposit. Same waxy deposit we can find in kidney. Okay. So waxy deposits due to deposition of amyloid all over the surface of liver. Then microscopy. These are hepatocytes. Hepatocytes. These are the basement membrane, and there is the accumulation of amyloid. Okay. So these are the hepatocytes. And this is the extracellular deposition of amyloid, the pink eosinophilic irregular waxy material. Okay. Extracellular, this is cell, this is within the cell, but this is outside the cell. So the deposition is entirely extracellular and eosinophilic. This is basophilic. The nucleus is basophilic due to contents of nuclear protein. It stains like purple, deep purple, but the cytoplasm part, the extracellular protein part, they always stain in hematoxylin eosin stain as pink or bright pink. So this is eosinophilic extracellular deposition just outside of the hepatocytes, and this is the gross appearance of liver. This is enlarged and waxy. So where the deposits occur, amyloid in liver, space of decay. Space of decay, space between the hepatocytes and the sinusoidal endothelial cells. So everywhere the amyloid tends to appearing or depositing in the extracellular space near the basement membrane. Okay. So in gross, enlargement, pale, waxy and form, and histologically first appears in the space of decay, that is the space between the basement membrane and the hepatocytes. Okay. This is the hepatocyte, this is the nucleus of the hepatocyte. This is the hepatocyte, this is the border, normal hepatocyte, eta nucleus, nucleolus, and all the amyloids are eosinophilic, wavy, irregular, extracellular deposits. You can appreciate all the features, wavy, irregular, without boundaries and extracellular. No amyloid is seen to deposit within the cell, but it is entirely extracellular. Okay. বুঝতে পারছিস কি বলছি? ঠিক আছে। Now heart, bigger heart. So this is a case of senile systemic amyloidosis, and this is the picture. Originally all the gross specimen picture are from the autopsy tissue. Okay, from the Department of Forensic Medicine. Whenever the patient voluntarily or the family members of the dead voluntarily appears for the biopsy, autopsy or postmortem, then we can get such kind of specimen in our museum. So this is enlarged heart. Okay, the heart is enlarged, you can appreciate, and the intraventricular septum, that is IVS, that is the wall, that is the muscular wall between two ventricles. This is the left ventricle, the thicker wall. This is the right ventricle, the thinner wall. Okay, and this is the intraventricular septum. You just appreciate the thickness, the increased thickness. It is huge, it is heavier, and it is broader. Okay, amyloid also deposits is in subendothelial. Okay, endothelial, this is the endocardium, this is the myocardium, this is the epicardium. Okay, so amyloid tends to deposit in the endocardium and the myocardium. Okay, previously known as senile cardiac amyloidosis because it is commonly seen in elderly patients. Restrictive cardiomyopathy and arrhythmia. Restrictive cardiomyopathy, why? Because the decrease the elasticity of the myocytes or the cardiac muscle. মাসেলের উপরে মাসেল ভারী হয়ে গেছে, মাসেলের উপরে ডিপোজিশন হয়েছে, তাই জন্য মাসেলের ইলাস্টিসিটি, তার কন্ট্রাক্টিলিটি লস্ট হয়ে যাচ্ছে, তাই জন্য রেস্ট্রিকটিভ কার্ডিওমায়োপ্যাথি। দ্য হার্ট ইজ নট এক্সপ্যান্ডিং লাইক ইট ওয়াজ বিফোর। আরেকটা কি হয়? অ্যারিথমিয়া। অ্যারিথমিয়া কেন হয়? আমরা পড়েছি কেন কে পেসমেকার, এসএ নোড, এভি নোড, তাই তো বান্ডেল ব্রাঞ্চ যেগুলো আছে, ফ্যাসিকেলস, তো সেইখানে যদি অ্যামাইলয়েড ডিপোজিট হয়, মেনলি যেটা আমাদের পেসমেকার বলে এসএ নোড, যেটা রাইট এট্রিয়ামের সামনে থাকে, আপার রাইটে, তাই তো? রাইটই তো, ঠিক আছে, ভুলে যায়নি। তাহলে রাইট এট্রিয়ামের আপার রাইটে থাকে, তো সেখানে যদি আমাদের কখনো অ্যামাইলয়েড ডিপোজিট হয়, ইফ অ্যামাইলয়েড ডিপোজিটস অন দ্য নোড ইটসেলফ, দেন দ্য পেশেন্ট dies of arrhythmia, cardiac arrhythmia, and that is the most common cause of death in the patient of senile amyloidosis involved heart or restrictive cardiomyopathy. Familial amyloid polyneuropathy may be common, but not in our country, and the protein that is deposited, that is ATTR type. This is a type of protein. Other A transerythrin, okay, ATTR. Other proteins are AL, AA, beta amyloid. How the names are formed, what are the composition of different proteins of amyloids, like heart, brain, kidney, liver. All the proteins that are deposited as amyloid are not same in constituent or chemical structure, okay. How their chemistry differ, that will be taught in your tomorrow class. Please do present, everybody, okay. So one type of protein is ATTR. Now this is, just see, the cardiac chamber are gradually and extensively diminished in size, and the thickness of the interventricular septum and as well as the left ventricular wall. এই amyloid দেখতে পাচ্ছিস, whitish material, lardaceous change, lardaceous spleen also we can get in spleen. So this is the gross picture, okay. The picture or the features we can appreciate through our naked eye. So this is the biopsy picture or histopathological examination. This is the cardiac myocytes, the longitudinal arrangement of cardiac myocytes you can appreciate. This is the nucleus, elongated muscles, fibers, skeletal muscle fiber, cardiac muscle, voluntary নয় কিন্তু striations আছে, তাই তো, unique type of muscle is cardiac muscle, ওকে, তাই তো। তাহলে এদের অ্যারেঞ্জমেন্ট হচ্ছে আমাদের হরাইজন্টাল, লাইক আ ফিগার অফ 8। তো সেখানে এক্সট্রা সেলুলার ডিপোজিশন অফ অ্যামাইলয়েড আর ইওসিনোফিলিক মেটেরিয়াল। তাহলে কি হয়েছে, অ্যারিথমিয়া হতে পারে, কেন হতে পারে বলেছি, কন্ডাকশন সিস্টেম, লোকালাইজ ফর্ম ডিপোজিট ইন লেফট এট্রিয়াম, যেটাও বলেছে, অ্যামাইলয়েড ফার্স্ট ডিপোজিট ইন সাব এন্ডোকার্ডিয়াম এরিয়াস অফ দ্য এট্রিয়াম। সো সাব এন্ডোকার্ডিয়াম is the first place where the amyloid starts to accumulate, but with the progress of time amyloid deposition increases from endocardium, subendocardium to myocardium and outward to epicardium, okay. So the first place of deposition is subendocardium. Cardiac failure, cardiac arrhythmia, gross heart is enlarged and firm. So every organ that is affected by amyloidosis is enlarged. So only this point you should not forget, or it is impossible to forget. So epicardium, endocardium and valve show tiny nodules, maybe in this picture, tiny nodules, endocardium nodule, okay. And microscopic focal subendothelial accumulation, primary form, and deposits are seen around myocardial fibers in ring form as well as ring fibers. So this is secondary amyloidosis affected in heart, and this is ring form, okay. Extracellular eosinophilic, this is extracellular, and this is not a cellular deposit. Every cell that contains a nucleus, these are muscle fiber, contains nucleus, but this thing is not having a nucleus, and this is a protein, and this is eosinophilic, irregular, and here around the myocyte and besides the myocyte it takes a form of a ring. So this is also called as ring fiber, but the thing is same. Now next or last, amyloidosis of brain, okay. The protein, namely A beta amyloid, A beta amyloid protein, diseases associated with senile amyloidosis, Alzheimer disease, like dementia, neurodegenerative disease, multiple sclerosis, all these kind of neurodegenerative diseases, amyloidosis like picture in brain we can find, okay. So this is the characteristics neurofibrillary tangle, okay. This is Purkinje fiber, this is brain tissue, Purkinje fiber, and this is the neurofibrillary tangles, okay, like stellate shaped or comet shaped, ধূমকেতুর মতো। So this is the characteristics, very important for your MCQ purpose, neurofibrillary tangles. কালো কালো এটা অন্য স্ট্রেন, সিলভার স্ট্রেন, this is another strain, এটা এটা দিস ইজ নিউক্লিয়াস, এইগুলো নিউক্লিয়াস তো, এইটা নিউরোফিব্রিলারি ট্যাঙ্গেলস, দেখতে এই ছবিতে পরিষ্কার, নিউরোফিব্রিলারি ট্যাঙ্গেলস, এই যে এ বিটা অ্যামাইলয়েড প্রোটিন। ওকে, সো এক্সট্রাসেলুলার নিউরোফিব্রিলারি ট্যাঙ্গেল সিন ইন হিস্টোপ্যাথোলজি, সেটা ব্রেনে দেখা যায়। এটা হার্ট, iodine staining of amyloid, apply Lugol's iodine on cut surface, the area contain amyloid stay deep brown, ঠিক আছে? এটা this is the way to demonstrate amyloid in gross specimen. First apply Lugol's iodine, then add diluted sulfuric acid, so the blue coloration of the affected part. This test is not done nowadays. এই amyloid, এটা অ্যামাইলয়েড, এই যে এক্সট্রাসেলুলার প্রোটিন। ওকে, দেখতে পাচ্ছিস সবাই, বুঝতে পারছিস? এক্সট্রাসেলুলার ইওসিনোফিলিক অর্গান, সেলের মধ্যে নয়, সেলের বাইরে জমে, এক্সট্রাসেলুলার ডিপোজিশন। এই যে এইটা দেখিয়ে দিই তোদের, কঙ্গোডেট স্টেন, স্পেশাল স্টেন টু ডেমনস্ট্রেট অ্যামাইলয়েড ইজ কঙ্গোডেট পিকচার or every histopathological picture. The stain is called hematoxylin eosin or H&E stain. That is most commonly practiced in histopathological laboratory. Okay, but there are few special stains to demonstrate the protein or to demonstrate the amyloid in a definitive pattern. কেন এই স্পেশাল স্টেনগুলো আবিষ্কার করার দরকার পড়লো বা এগুলো কথা মাথায় এলো প্যাথোলজিস্টদের? তার কারণ এই যে এক্সট্রাসেলুলার যেই ডিপোজিশনটা, এই যে এক্সট্রাসেলুলার যেই ডিপোজিশনটা, it can mimic to any protein, any necrotic part, any protein or any extracellular deposition of like crystal, okay, necrosis, like other proteins other than amyloid, they all can look like a same thing or same appearance in H&E stain. ওকে, মানে দেখতে একই রকম, অ্যামাইলয়েড ছাড়াও যদি অন্য প্রোটিন জমে ওখানে, তো দেখতে একই রকম লাগবে, এরকম ইওসিনোফিলিকই স্টেন নেবে, এর ইওসিনোফিলিকই লাগবে দেখতে, এরকম পিঙ্কিশই লাগবে দেখতে, এই যেরকম পিঙ্কিশ, মোর ওভার সবই কিন্তু পিঙ্ক, তাই তো? এটা অ্যাপ্রিসিয়েট করতে পারছিস তো H&E স্টেনে? তো স্পেশাল স্টেনগুলো আমাদের অ্যামাইলয়েডের প্রোটিনের কেমিক্যাল স্ট্রাকচার যেরকম আছে সেইগুলোকে হাইলাইট করে, কিভাবে? স্পেশাল অ্যাপিয়ারেন্স দেয়। সেরকমই একটা এই ছবিতে দেখা যাচ্ছে, সেটা হচ্ছে ভেরি ক্লাসিক্যাল মাইক্রোস্কোপি অ্যান্ড ভেরি ক্লাসিক্যাল স্টেন। এটা হচ্ছে স্পেশাল স্টেন, অ্যামাইলয়েড পজিটিভিটি উইথ কঙ্গোডেট স্টেন, দিস ইজ স্পেশাল স্টেন, দিস ইজ, you can definitely say this is amyloid deposition, and under polarized microscopy the protein are giving hue like green apple birefringence, green apple birefringence, okay, apple green birefringence, birefringence মানে এই যে যেই কালারটা মানে রিফ্র্যাক্টাইল কালার দুটো আছে, বুঝতে পারছিস? সবুজ কালারটাও রিফ্র্যাক্টাইল, আবার এই পিঙ্ক এই ইয়ে কালারটা, এই যে গোল্ডেন ইয়েলো কালারটা, সেটাও দেখতে পাচ্ছিস রিফ্র্যাক্টাইল। আর এই ব্যাকগ্রাউন্ড স্টেন, নেগেটিভ স্টেন হচ্ছে ডিপ ব্লুটা, এটা পোলারাইজড মাইক্রোস্কোপের ছবি, বাই রেফ্রিঞ্জেন্স, তাহলে গ্রিন ব্লু বাই রেফ্রিঞ্জেন্স, অ্যাপেল গ্রিন। এটাও একই জিনিস, ক্রিস্টাল এক্সরে ক্রিস্টালোগ্রাফি করেছে, ইনফ্রারেড স্পেকট্রোস্কোপি করেছে, ডিপোজিশনটা। এগুলো নর্মাল মাইক্রোস্কোপ নয় কোনোটা, এগুলো আইদার হচ্ছে ইমিউনোফ্লুরেসেন্স মাইক্রোস্কোপ, আইদার পোলারাইজড মাইক্রোস্কোপ, নর্মাল লাইট মাইক্রোস্কোপ নয়, সোর্স লাইট নয়, ঠিক আছে? এই যে বিটা প্লিটেড শিট, পলিপেপটাইড চেন, ক্লাসিক অ্যাপেল গ্রিন বাই রেফ্রিঞ্জেন্স আন্ডার পোলারাইজড লাইট। So this is the only few things that you should not forget about amyloidosis, that is the appearance of amyloid protein in polarized microscopy or in special stain. These things you must not forget, okay? Congregate, special stain. Everybody asks this question, every examiner. Apple green birefringence under polarized microscopy, these terms also you should not forget, okay? Amyloidosis morphology, same thing. Hematoxylin and eosin. Okay? Extracellular material. Extracellular material. So gross organ is large and grey, waxy and rubbery. And microscopy te ki bolche? Always extracellular. Begins between cell close to the basement membrane are amorphous and eosinophilic. Amorphous mane? No morphology. Amorphous, no morphology. But lacking morphology. So no definite boundary, no definite border. So this is the nutshell. Whatever may be the organ, just gross appearance will be large, grey, waxy and rubbery. And microscopy, always amorphous, extracellular material, eosinophilic material and near to the or close to the basement membrane. This is also special stain, von Cossa stain. This is the amyloid basement membrane. বুঝতে পারছিস? খয়েরি হয়ে গেছে, এটা হচ্ছে তোর সিলভার কন্টেনিং স্টেন। এই যে অ্যামাইলয়েড এ অ্যান্টিবডি ইমিউনোহিস্টোকেমিস্ট্রি আইএসসি করেছি। ঠিক আছে, এগুলো দেখবি সব। এটা বায়োপসি, এটাও এই যে একই রকম বায়োপসি পিকচার, কিরকম দেখতে লাগবে পোলারাইজড মাইক্রোস্কোপিতে বা ইনফ্রারেড স্পেকট্রোস্কোপিতে। এই অ্যাপেল গ্রিন বাই রেফ্রিঞ্জেন্স, এটা বলা যাবে না এই কথাটা, অ্যাপেল গ্রিন বাই রেফ্রিঞ্জেন্স। এটা হচ্ছে প্যাস্টেন, পিরিয়ডিক অ্যাসিড স্কিপসেন, এই যে অ্যামাইলয়েড জমেছে, এক্সট্রাসেলুলার ব্রাইট পিঙ্ক। ঠিক আছে, ব্রাইট পিঙ্ক ডিপোজিশন এক্সট্রাসেলুলার। এই যে গ্লোমেরুলার বেসমেন্ট মেমব্রেন, এটা গ্লোমেরুলাস, তার চারপাশে এক্সট্রাসেলুলার মেটেরিয়াল জমেছে। এটা স্পেশাল স্টেন আমরা করেছি, তাহলে প্যাস। কিন্তু মোস্ট কমন যেটা বলা যাবে না সেটা কি? হ্যাঁ, অ্যাপেল গ্রিন বাই রেফ্রিঞ্জেন্স, সেটা হচ্ছে পোলারাইজড মাইক্রোস্কোপে। আর স্পেশাল স্টেন কোনটা বলতে হবে? ইয়েস, একটা কান্ট্রির নামে, আফ্রিকান কঙ্গো, কঙ্গো রেড। থ্যাংক ইউ।